So let's go back to where we left off last time we met. So the last time we met, we were looking at the different types of pressures that are found within the glomerulus, as well as within Bowman's capsule. And so it gets a little confusing because there's different ways that these pressures are referred to. So let's just kind of go over them, and I'll tell you some of the alternative terms that we can use to describe these different phenomenon. So within the blood, so this is going to be blood entering into Bowman's capsule. You're going to have within the glomerulus, that's going to be glomerular hydrostatic pressure. And so over here, that would be PG. That's going to be determined by the pressure of your blood. So the blood pressure is going to be determining this. So if you have increased amount of blood pressure, you're going to have an increased amount of filtration. So filtering urine and all other waste products out into the capsular space. Okay, so that's going to be glomerular hydrostatic pressure, also referred to as P little g. So big P for pressure, little g for glomerulus, and then it's also referred to as GHP, glomerular hydrostatic pressure. Now, glomerular osmotic pressure, also referred to as pi g, or glomerular osmotic pressure, GOP. That's going to be determined by large things floating in the blood. So we're talking like proteins, we're talking about albumin. Okay, so it's similar to what we were dealing with when we were dealing with capillary pressures, right? The capillary hydrostatic versus capillary osmotic pressure. So very similar in terms of filtration of urine. So the GHP is going to be is going to be forcing urine out of the blood into the capsular space. The glomerular osmotic pressure, on the other hand, is going to be like attracting, right? It's going to be trying to pull solutes back into the blood, into the glomerulus. Okay, so these are going to be opposite direction in terms of their flow. Then within the filtrate, which is going to be the actual urine itself, you have capsular hydrostatic pressure. So that's going to be the pressure that's within Bowman's capsule, trying to push back into the blood, back into the glomerulus. And then you have capsular osmotic pressure, which is also referred to as pi BC. When you see BC, we're talking Bowman's capsule. Okay, so Bowman's capsule, also referred to as just the capsule. So pi BC would be the pressure within Bowman's capsule in terms of osmotic pressure. Now, in reality, this osmotic pressure within Bowman's capsule should be zero. There shouldn't be anything in terms of proteins found within Bowman's capsule, right? Because proteins are going to be, by and large, too big for them to filter through the glomerulus. Now, you can, at some point, if you have renal damage, you can start seeing proteins building up within the filtrate, and also proteins within the urine. We call that proteinuria. Okay, that's usually indicative of renal injury, renal failure, which we're going to talk about a little bit later when we discuss like urine analysis, and then also the different components that make up urine. So in reality, the capsular osmotic pressure in a normal, healthy individual should be zero. Right? So there shouldn't really be any pressure, basically, or any large proteins that would be like pulling filtrate into the capsular space. So the major ones that we're going to be dealing with are going to be the glomerular hydrostatic pressure, and then the capsular hydrostatic pressure pushing back into the glomerulus. So if you want to calculate net filtration, you would take the glomerular hydrostatic pressure plus the capsular osmotic pressure. So that should actually be zero right there. So this in reality should really not be anything. So you could just kind of scratch that off, right? Because there should be no pressure. In other words, the main pressure is going to be the pressure pushing from the blood into the filtrate. And then you would subtract the pressure within the Bowman's capsule. That's the hydrostatic pressure pushing back into the capillary, as well as the oncotic or osmotic pressure within the glomerulus. So in other words, trying to attract filtrate back into the blood. So here's another breakdown of all these different values. So the glomerular hydrostatic pressure, that's going to be associated with blood pressure. That can also be affected, which we'll talk about in a little bit, by whether or not the afferent or efferent arterioles are dilating or constricting. Those factors could also have a huge implication in the glomerular hydrostatic pressure. So I'll give you a couple problem examples in a moment that can demonstrate what that looks like. The glomerular osmotic pressure, just think about proteins. That's going to be albumin. Okay? Albumin that's trying to attract, filtrate back into the blood. Then within Bowman's capsule, you have that capsular hydrostatic pressure. That's going to be pressure from the filtrate back into the blood. And then your capillary osmotic pressure, which should be theoretically zero unless there's renal damage taking place. So here's another overview of all that we just discussed over here. So the most important one out of all of these is going to be this guy over here, right? So that's your glomerular hydrostatic pressure. That's going to be pushing solutes out of the blood into the capsular space. So that's going to be the first one that's really important here. Glomerular hydrostatic pressure. Okay, that's going to be determined by the blood pressure within those vessels. Then the other one that's going to be important is going to be pushing back into the back into the glomerulus, capsular hydrostatic pressure. So that's going to be operating in the opposite direction of the glomerular hydrostatic pressure. And then the next one would be the blood colloidal pressure, which in the previous slide, we referred to that as the glomerulus osmotic pressure. So this is kind of where it gets a little confusing. The blood colloidal pressure is the same thing as the glomerular osmotic pressure. So it gets a little bit confusing, but if you understand the concepts, it should make sense ultimately, regardless of the terminology that you use here. And then the capsular colloidal osmotic pressure should be zero because you shouldn't have any protein within the urine. And then we can calculate the net filtration pressure using these different values. So let's go ahead and go through an example of how you calculate the net filtration pressure. So the first one that's really important is going to be that glomerular hydrostatic pressure over here. So let's pretend that it's 50 millimeters of mercury. Okay, so that would be pushing out of the glomerulus into the capsular space. Then the one that's pushing in the opposite direction is going to be the capsular hydrostatic pressure. So that's going to be this guy over here. So let's pretend it's 15. The net hydrostatic pressure, you would take 50, subtract 15, and then that would be 35 millimeters of mercury. And then you would also take into consideration the blood colloid osmotic pressure, which would be trying to attract, filtrate back into the blood, back into the capillary. Okay, so that would be going in the opposite direction, back into the capillary. Say that's 25 millimeters of mercury. Then your total filtration pressure would equal to 10. Okay, so that's going to be the total amount of pressure pushing filtrate out of the blood. So that's how you can use those different values to calculate for both net hydrostatic pressure as well as the filtration pressure. Let's move forward here. Okay, there we go. Sorry, this thing was freezing on me. So GFR. GFR is something that you guys are going to be dealing with a lot when you guys are working in clinic. GFR is effectively the measurement of the amount of urine that's produced within a minute. The average GFR, or glomerular filtration rate, is going to be about 125 milliliters per minute. A lot of blood is going to be entering through the kidneys to get filtered out. And the glomerulus does indeed produce a lot of filtrate every single day. So you're producing about 180 liters of filtrate. That is a lot of fluid that's being produced. Now, the good thing is you're getting filtration at the level of the glomerulus, but then at the level of the proximal convoluted tubules, as well as the portion of the loop of Henle, talking about the descending loop of Henle, you're getting a lot of water reabsorption. So the majority of the water that's being filtered out is actually going to be reabsorbed in the kidney, right? So thank God for that. Otherwise, you'd be using the restroom all day long. Now, one of the big thing about filtration pressure, that's going to be what helps you calculate the amount of filtration or filtrate that's coming out of the glomerulus. And there's going to be a couple things that affect filtration pressure. One thing is that at the local level, which I'm talking about the afferent and efferent arterioles, whether or not they're dilating or constricting, that's going to be locally determined, and it's all through autoregulation. So I'm going to show you a couple practice problems of what that looks like in a moment here. We also have hormonal regulation taking place. What are some of the hormones that we deal with when it comes to maintaining blood pressure at the level of the kidneys? You guys remember some of them? Angiotensin for sure, but renin for sure is going to be one of the more important ones because that's actually released by the juxtaglomerular cells. Also, important hormones would be antidiuretic hormone, right, to prevent fluid loss. And then, what's another one? What's one that balances salts? Aldosterone, yeah, exactly. So aldosterone is going to be really important. So that's all going to be hormonal regulation, and we're going to talk about that in chapter 24. So it's going to be sort of like a review for stuff that we've already talked about in previous chapters. And then you also have autonomic regulation. So we're going to talk about that again in chapter 24, but autonomic regulation. So for instance, if you're out jogging or exercising, if you're in like a sympathetic state, if you're in a sympathetic state, that's going to actually reduce the amount of blood going towards the kidneys. Okay, it's going to increase the amount of blood that's being sent to other tissues. For instance, skeletal muscle, also your skin, so that you can, help to sweat, so you can undergo thermoregulation. So those are going to be things that all affect the amount of GFR, or glomerular filtration rate. Now, GFR can be affected, as I mentioned, by some of the local controls. So if the local blood pressures within the afferent and efferent arterioles start to change, then that's going to result in either vasoconstriction or vasodilation of those afferent and efferent arterioles. And so that's going to be taking place at the level of the juxtaglomerular apparatus. There's also going to be those mesangial cells within the glomerulus itself that can help to either vasodilate or vasoconstrict those capillaries. So let's go into a couple different problems here. Actually, let's go over this too real quick here. So in terms of the macula densa, so you got the juxtaglomerular cells, which are going to be receiving information basically from the macula densa, as well as the afferent and efferent arterioles. So it's going to be able to measure the amount of pressure within the blood vessel itself, versus the macula densa, which is specifically getting information from the distal convoluted tubules. So if any sort of pressure change is going to be affecting those different cell types. And so you get stretch receptors within those regions that are basically going to be able to tell your capillaries to either vasoconstrict or vasodilate. So let me just go over some of these problems here. So your afferents, those are the ones that are coming into the glomerulus, right? And that's where you're going to see filtration, net filtration of urine. And then your efferents are going to be what bring blood out of your glomerulus. Now, if there's any sort of local changes in blood pressure, those local changes in blood pressure are either going to increase or decrease the total amount of GFR, or glomerular filtration. Now, if you had a decrease in blood pressure, a reduction in blood pressure, either because you have, if you might be a little bit dehydrated, perhaps, perhaps there's not enough blood coming through, you're going to get a reduction in your GFR, okay? Now, with that reduction in GFR, you're going to want to maintain the amount of urine production because you want to constantly be filtering blood, right? That's going to be the major function of the kidneys. So if you get a reduction in GFR, so your kidney is going to want to reflexively increase GFR. So what's going to happen? You're going to get vasodilation of your afferents. So your afferent arterioles increase in diameter. So you're going to get more blood coming through the glomerulus. That's going to start increasing the amount of filtrate. Also downstream, you're going to get constriction of the efferents, right? So if you get constriction of the efferents, the blood is going to start pooling a little bit more in the glomerulus, and you're going to start increasing the overall pressure within the glomerulus, allowing more filtrate to come out into Bowman's capsule. So if you want to talk about it in terms of preload and afterload, kind of like what we were discussing in cardiovascular, when you have afferent dilation, that's going to be an increase in your preload. Efferent constriction, that's going to be an increase in afterload. So you're going to have to be you're going to have more force to pump against the increased amount of pressure from the vasoconstriction in the efferent arterioles. So the overall goal of this is going to be to increase the amount of GFR. Because as I mentioned, you want to maintain the amount of glomerular filtration because you want to try to filter out all those toxins that are developing, that build up in the blood and circulatory system. Now, with the opposite effect, if you have increased GFR, you're producing way too much urine, your kidneys, again, are going to try to control that at the local level. So you're going to get a reduction in your preload through vasoconstriction of your afferents. Okay, so you can get a reduction in blood that actually makes it to the glomerulus. And then you're going to get also increased efferent vasodilation, which reduces the afterload. So you have less pressure to pump up against. So in other words, you have less blood coming in. The blood that does enter into the glomerulus doesn't have to face a lot of pressure to exit because you have the vasodilation of the efferents. And so now that's going to overall decrease the amount of GFR. So this is basically the way for you to maintain homeostasis through autoregulation. So this little chart from your textbook discusses homeostasis in terms of decreased filtrate, decreased urine production, reduction in GFR. So what would happen? You get dilation of the arterioles, the afferent arterioles, the ones that are coming into the glomerulus. So you get more blood coming through the glomerulus. You also get contraction of those mesangial cells. So those mesangial cells, if you remember, those are the ones that are within the glomerulus itself. If those contract, then you're going to get vasodilation of your capillary beds. So if you get more blood coming through the capillary beds, you're going to get more blood being able to filter out through those fenestrated capillaries. And then you're going to have constriction downstream. So that increases your afterload. So what happens? You get an increased GFR as a consequence. So any questions on autoregulation at the local level? Does that make sense to you guys? Okay, I'll give you guys a couple of practice questions later because you definitely need to know that for your exam. Now, in terms of hormones, some of the most important hormones are going to be what we've already discussed in the past, so the renin, angiotensin, aldosterone system. So renin, of course, is going to be released at the level of the kidney, right? So renin, once it gets released, it helps to convert angiotensinogen into angiotensin 1. So we'll go over that whole entire cascade throughout chapter 24. And then the other thing that's also important is something that we discussed a lot earlier in this semester. So these are going to be hormones, the peptides that are going to be released from the heart, right? So you have both ANP and BNP. ANP, that's atrial natriuretic peptide. BNP is going to be brain natriuretic peptide, but in reality, BNP is mostly produced and released from your ventricles. Okay, so don't be confused about BNP. It's going to be mostly associated with the ventricles. That's going to be a result of increased blood pressure, increased blood volume. If you have too much blood volume and too much blood pressure, that's going to trigger both the atrium and the ventricles to release ANP, BNP, which are going to help to reduce the overall blood pressure. And so what do? It's natriuretic, so that means it's going to be involving sodium. So you're going to be excreting sodium at the level of the kidneys. So when you excrete sodium, water follows solute, you decrease your overall blood volume. So that helps to reduce your blood pressure. So this is going to be completely opposed to the renin, angiotensin, aldosterone system because the RAAS, the whole goal is to overall increase your blood volume and to increase your blood pressure. It's also going to oppose antidiuretic hormone, right? Antidiuretic, which helps you to retain water, right? So if you have ANP and BNP released, you're going to lose more water as a result, thereby reducing your overall blood volume. So before we get into chapter 24, let's go ahead and do a couple questions for part 2 on chapter 23. I only made a few questions on this one, so let's go ahead and log in. Okay. So I'm going to go ahead and hit start. If anyone wasn't able to log in, just give us your name. All right, awesome. So if you have increased blood volume, that means you have more blood arriving at the level of the kidneys. If you have more blood coming to the kidneys, you're going to have ultimately more filtration of urine at the level of the glomerulus. So it's pretty straightforward stuff if you just understand like fluid dynamics. Any questions about that? For those who said decrease, what was your logic if you want to volunteer your reasoning why you thought it would decrease? Anybody want to volunteer? Okay, so so just know if you have more blood coming to the kidneys, you have increased filtration. All right. Oh, good. Most of you guys got that correct. That's awesome. So yeah, glomerular hydrostatic pressure, right? It's going to be opposed by the capsular hydrostatic pressure. Okay, so there are going to be forces pushing in the opposite direction, but by and large, the pressure coming off of the glomerulus is going to be a lot higher. Okay, so you're going to get net filtration. Cool. So most of you guys got that correct. So I'll go ahead and move on. Okay, good. The majority of you guys got that correct. GFR, that's glomerular filtration rate. In a normal individual, it's roughly 125 milliliters per minute. So quite a lot of fluid being filtered every minute. But like I mentioned earlier, over 99% of all of that fluid is eventually going to be reabsorbed at the level of the proximal convoluted tubules, as well as the descending loop of Henle. All right, last one before we go to chapter 24. All right, so we haven't gotten to the collecting system yet. So I put that in there, sort of putting the cart before the horse a little bit. But the collecting system, that's going to be the very last portion before you get to the renal papilla, and then down into the minor calyces, major calyces, before urine eventually makes its way to the ureter and then down into the bladder. So the collecting ducts are going to be found within the renal medulla, and so they're going to be receiving urine from all the distal convoluted tubules from each of the nephrons. Okay, so the main thing that the collecting system actually does, it just kind of does these final little alterations just to change the volume of the fluid a little bit, as well as minor adjustments to solute concentration. Other than that, the collecting ducts don't do much aside from just collecting urine, but they do a little bit of minor adjustments before urine gets released into the ureters. So don't worry if you got that wrong. Absorbing nutrients, plasma proteins, ions, that's mostly going to be throughout like the proximal convoluted tubules, distal convoluted tubules, as well as the loop of Henle. Proteins, you should never get proteins in your urine unless there's kidney damage. Okay, so if there's like glomerulonephritis or something like that, that might cause proteinuria. So you really shouldn't have proteins. So that just that the fact that proteins wasn't included in that answer, that would have been incorrect. Okay. So that was it for chapter 23. Now, chapter 24 is a lot of similar information, so it kind of like builds off of each other. All right, good job, Valerie. Get a high five. All right, let's move on. Chapter 24. So chapter 24 effectively is just a continuation of chapter 23, but a little bit more granular detail. We're going to go into a little bit more detail as to what the proximal convoluted tubules, loop of Henle, distal convoluted tubules, what those actually do, like what kind of fluids you see being exchanged, what kind of solutes you see actually being exchanged, the things that affect the transfer of solutes at those levels. So we'll go into more details about that here. So let's briefly touch base again on all the hormones that are going to be involved in the urinary system. So to reiterate, we're going to be, renin is going to be one of the most important ones that comes into play. What does renin respond to? Does it respond to increased blood pressure or decreased blood pressure? It responds to decreased blood pressure for the purpose of eventually increasing your overall blood pressure as well as your overall blood volume. So that's what renin is going to be doing. And then we already discussed what the natriuretic peptides do. So ANP and BNP. ANP from the atria, BNP from the ventricles. Just know that they're going to oppose aldosterone as well as antidiuretic hormone. And the goal of those would be to excrete sodium so that you can thereby excrete more water, just because water follows solutes. So you would eventually decrease your amount of blood volume, blood pressure, and all of that. So the main thing that's going to happen is low blood pressure, low blood volume. That is the major thing that's going to trigger the renin from being released at the level of the juxtaglomerular cells. Okay, so the juxtaglomerular apparatus is what releases renin. You're also going to have sympathetic innervation that comes into play here. So we'll talk about how sympathetic activation can help to affect renin release. And then osmolarity of filtrate. So in other words, if you had too little sodium and your urine was super diluted, you're going to want to release more aldosterone. Renin is going to be one of the first steps in that whole cascade. So eventually, aldosterone is also going to be released as a response to angiotensin II. When angiotensin II is released, it's not going to just cause vasoconstriction, because remember, angiotensin II is a very powerful vasoconstrictor. It's also going to help to stimulate the release of aldosterone at the level of the adrenal glands. You guys remember where the aldosterone gets released from? Which level? Huh? It's going to be the most outer layer, which is what? Zona glomerulosa? Good. Awesome. Glad you still remembered that. So the zona glomerulosa is what helps to release mineral corticoids, okay, aldosterone, which helps to maintain balance of sodium as well as potassium. So we're going to talk about all that in a little bit. So if you had very little sodium within your urine, that means your urine was super dilute. So you're going to want aldosterone to help bring in more sodium, okay, so you can help further concentrate the amount of urine. So pressure changes at the level of the glomerulus. If the pressure drops, right, you might have reduction in blood volume. You're going to it's going to affect how much GFR is going to be, the level of GFR, right? So if you have reduction in pressure, then you're going to have a reduction in GFR. If you have stimulation of the juxtaglomerular cells, right, so that's going to help to release renin. You're also going to have baroreceptor reflexes coming into play at that level as well. And so that's going to be due to sympathetic activation. So if your blood pressure was really low, remember you have a bunch of baroreceptors in your body that can, help signal your heart, for instance, to beat faster, be more robust, so that you can help to increase your blood pressure. You're also going to have reduction in blood pressure affecting those baroreceptors, and those baroreceptors are also going to help increase sympathetic activation, which is going to thereby increase renin release. So if you have reduced blood pressure, sympathetic activation takes control. That's going to also affect the amount of renin that's released. And then decreased sodium concentration, which we just talked about a second ago. If you have too little sodium, you're going to want to increase the amount of aldosterone so that you can increase sodium reabsorption and thereby increase the amount of water that's being reabsorbed. Now, here's something that's kind of important about renin, is that renin is going to, so the increase in sodium is only going to be affecting renin secretion minimally. So it's not as much as these other factors. So blood pressure is really important in terms of like the major factor affecting renin release. So here's the whole entire cascade. We already went over this before, but it bears repeating because there's a lot of steps that are involved. The liver is going to be producing angiotensinogen. Angiotensinogen only gets activated once renin is released. Okay, so when renin is released, you get angiotensinogen, which helps to convert to angiotensin 1. Once angiotensin 1 makes its way to the lungs, at the lungs you have ACE, right, which is angiotensin converting enzyme, which helps to convert angiotensin 1 into angiotensin 2. Angiotensin 2 is the active form. Once angiotensin 2 gets released, then you have a bunch of other stuff happening. So you get the adrenals, which help to release aldosterone. By the way, angiotensin 2 is also going to help to vasoconstrict. But then aldosterone release is going to help stimulate sodium reabsorption, water reabsorption, and then ultimately the goal is to increase your blood pressure. So make sure you know each of these steps along the way with the renin-angiotensin aldosterone system. Now this is what's going on in terms of sodium chloride levels within the distal convoluted tubules. So if you recall, the macula densa is going to be what's found within the distal convoluted tubules. And so the macula densa is going to be able to respond to changes in sodium chloride levels. So if you had low sodium chloride levels, that might be indicating that perhaps you have lower levels of glomerular filtration. And so you're going to have a couple different things coming into effect. You might get the release of renin so that you can increase your GFR, so you can increase urine production. And then you might also get changes in the dilation of your afferent versus efferent arterioles. And so that all is basically going to help to affect the overall fluid level in your body. So let's go over some of these hormones. Renin, what does that help to convert? Angiotensinogen to angiotensin 1. Then you get angiotensin converting enzyme, which helps converting angiotensin 1 into what? Angiotensin 2. Good. And then the overall effect of angiotensin, the renin-aldosterone system, is going to be to increase the hydrostatic pressure within the glomerulus. If you get increased hydrostatic pressure in the glomerulus, what's ultimately going to happen? So if you increase hydrostatic pressure in the glomerulus, what's going to happen to the GFR? It's going to go up, right? So you're going to get increased glomerular filtration as a result. So in terms of angiotensin II, recall that it's going to be a very potent and powerful vasoconstrictor. It's also going to preferentially constrict the efferent arterioles of the nephron. Now, if you get constriction of the efferents, what's that going to do to the GFR? Is it going to increase or decrease your GFR? It's because remember, the efferents are going to be downstream. That's where the blood exits out of the glomerulus. You have the afferents bringing blood towards the glomerulus, and then you have the efferents bringing blood out of the glomerulus. If you vasoconstrict the efferents, what's going to happen? Is blood going to start pulling up into the glomerulus? Is it going to maybe increase the pressure within the capillary beds in the glomerulus? So that's going to ultimately increase your GFR. Now, it's important to note that the vessels are all going to respond to angiotensin II, but the efferents are going to be the ones that respond the most. You do get a little bit of response at the level of the afferents, but the thing that the afferents are able to do to be able to counterbalance the effect of angiotensin II is the release of prostaglandins, the release of nitrous oxide. And so because of nitrous oxide is a vasodilator. So it's instead of constricting it, the nitrous oxide helps to relax and dilate the afferent arterioles. So it's going to preferentially constrict the efferents. Other things that are going to happen are going to be reabsorption of sodium, right? Because angiotensin II allows for the secretion of aldosterone. You're also going to get a thirst response too. And then you're also going to get antidiuretic hormone release. And antidiuretic hormone is going to help to prevent diuresis. So we're going to talk about ADH effects on the kidneys a little bit later. And then with the increased sympathetic tone, you do get an increase in your peripheral vasoconstriction throughout the rest of your body. So when we talked about cardiovascular system, when angiotensin II kicked in, it would increase the afterload. So the heart would have to pump up against more pressure. Other things that happen, you also get the sympathetic activation of the heart, so you're going to increase your cardiac output as well. Now, in terms of aldosterone, it's released from the adrenal cortex, right? The outer layer, so that's going to be the zona glomerulosa. That's going to be resulting in sodium reabsorption, right? So when you reabsorb sodium, that's going to be due to increased sodium pumps. So that's how you're able to actually bring sodium back into the kidneys and back into the blood. You're going to find a lot of these sodium pumps more in the distal convoluted tubules along with the collecting ducts. Remember that last question from chapter 23 that we just did, where it talked about the overall goal of the collecting ducts, what the collecting ducts do? This is going to be one of the things that it does. It kind of helps to do some fine tuning to the balance of sodium as well as water within the urine right before it gets excreted. And so you're going to see aldosterone affecting distal convoluted tubules and collecting ducts, and it's going to allow for sodium reabsorption. Now, if you had too much aldosterone in your system and you're absorbing a lot of sodium, you're going to be releasing a lot of potassium as well. And so one of the side effects of that would be hypokalemia. And so that's an important thing to keep in mind. And so this is where you're going to find aldosterone and those sodium transport pumps. You're going to find them all over here. This is all going to be distal convoluted tubules, and these are the collecting ducts. And that's where you see sodium channels, right? So you get a sodium pump that exchanges sodium for potassium, right? So they're both positively charged ions, and so that's how you're able to exchange one for the other. Okay, so we already went over this whole system over here, but one thing to keep in mind is that there are going to be negative feedback loops involved, okay? So there will be negative feedback. So if you go through this whole entire renin-angiotensin system, right, after you have an increase in your blood pressure, you have reabsorption of sodium, Once you have enough water retention and everything is kind of like back to normal, right, then you're going to have a negative feedback loop, which goes all the way back to the kidney, and it signals to the kidney to, hey, everything is good now, let's stop releasing renin. Okay, so that's one way that you can affect homeostasis within this whole entire system. And so here's another image that basically brings all of what we went over together. So it talks about what's going on at the juxtaglomerular apparatus with the release of renin. You have everything taking place in terms of the conversion, right, of angiotensin 1 to 2. And then you have how angiotensin 2 is going to help release aldosterone. And then aldosterone is going to help increase fluids, right? You're going to increase your thirst, your fluid consumption, also increase retention of fluids, increase sodium reabsorption, etc. So this is a really good chart that basically puts everything together in terms of what the hormones are all going to do within this system. So any questions on hormonal balance and how the hormones come into play in maintaining fluid balance? Awesome. So let's briefly go over autonomic regulation. So this is all associated with sympathetic, parasympathetic reaction. So say you're out jogging like these fellows over here. If you're jogging, you're going to want to be able to bring blood to where you have a heightened metabolic demand, right? So that's the goal of the circulatory system, right? To allow oxygenation of your peripheral tissues and to bring carbon dioxide back to the respiratory system so that you can undergo aerobic respiration. And so with sympathetic activation, you're going to have vasoconstriction with sympathetic activation, okay? So with vasoconstriction, what it does to your kidneys, you're going to get a reduction in your overall glomerular filtration rate. So it's actually going to slow down the amount of blood that's able to make it down to the glomerulus. So you're going to reduce the amount of filtration produced by the kidneys. So that's what's going on with exercise. If you're out jogging, you're going to have reduction in the amount of blood arriving at the kidneys. But this can also be a problem because if you have reduced GFR, if you have less amount of blood getting to the kidneys, that could potentially result in renal damage as well. So folks who are running a marathon, for example, you're doing exercise for a prolonged period of time, you might potentially get some form of kidney damage. Another thing to keep in mind that I didn't include here on these slides, there's a condition called rhabdomyolysis. Rhabdomyolysis is very common in patients who are strenuously exercising, like going a little bit overboard. Rhabdomyolysis occurs when you have a little bit of damage to skeletal muscle, and then eventually some of those components arrive at the kidney and can actually result in kidney damage. That can happen with strenuous exercise. That can also happen with drug use as well. So one of the more severe side effects of like amphetamine use, for example, where you have like heightened sympathetic activation, you could also get rhabdomyolysis as a consequence. Rhabdomyolysis can cause some severe damage to the kidneys. Other things that can affect this would be NSAIDs. So NSAIDs, ibuprofen, Advil, those types of drugs can also cause constriction of your afferent vessels. So you have a reduction in the amount of blood arriving at the glomerulus. You're also going to have a reduction in your overall GFR. So these would be considered hypoperfusion type injuries, right? So if you have too little blood arriving at the level of the kidneys, that can result in acute kidney injury, acute kidney damage. That's one thing to take into consideration. Cool. So let's go ahead and jump into each of these different regions in the nephron. So we went over all these a little bit superficially. So let's go into them in a little bit more detail. The background image that I put in here, we're gonna look at it a couple more times throughout the duration of chapter 24. But when you see the little P over here and the little D, P, that's gonna be proximal convoluted tubule. D is gonna be distal. Remember what you see within the proximal convoluted tubule, see all those little finger-like projections, right? All the microvilli. So you have a harder time to be able to see through the lumen when you look at a light microscopy histological slide. And then this large structure over here, that's the glomerulus, where you have all those capillary beds as well as the mesangial cells, etc. And then you have Bowman's space. Okay. So proximal convoluted tubule, that's going to be the first portion off of Bowman's capsule, right after the glomerulus. So remember, at the glomerulus, that's where you have filtration. At the level of the proximal convoluted tubule, that's where you start getting reabsorption, right? Remember, you're filtering a lot of filtrate per minute. So it's 125 milliliters of filtrate per minute. So it's a lot. So you want to make sure you reabsorb the majority of the fluids that are being filtered out. So that's where the proximal convoluted tubule start coming into play. The major cell type is cuboidal, okay? And then you're also going to have microvilli on the surfaces of those cuboidal cells within the lumen. So it allows for a lot of water and solute reabsorption. So that's the proximal convoluted tubules. These are the cells that you're going to see within those. So you're going to have 99% of stuff that passes through the proximal convoluted tubules, 99% gets brought back into the blood. Okay, so that's a really important thing to keep in mind. You're producing a lot of you're producing a lot of filtrate, but you're reabsorbing a lot of that, so you're not urinating as much. So glucose, for example, you do get filtration of glucose, a little bit of glucose, okay? And we're going to talk about the renal thresholds on Thursday. But generally speaking, if you have like a small amount of glucose in your blood and it gets a little bit filtered out in the glomerulus, it's not a big deal. You're eventually going to reabsorb the majority of that glucose at the proximal convoluted tubule. If you exceed the renal threshold for glucose, for example, that's when you start seeing glucose winding up in the urine. That means you have way too much glucose. The kidney's not able to properly reabsorb all of it, and then you wind up excreting it at the end. But in normal, if you're, of a normal level of glucose, you should be able to reabsorb it entirely. Other things that you see being reabsorbed are sodium, right? So when you reabsorb more sodium, you're able to also reabsorb more water. You can also see bicarb being reabsorbed. So the majority of the stuff that's going through the proximal convoluted tubule will eventually be reabsorbed in the end. Okay, moving forward. All right, so this is the overview of everything that's being reabsorbed. So follow the green lines. So over here, that's where you have filtration taking place. So you'd be filtering all sorts of things. Water is one. That's one of the major components. Also urea, which is going to be a breakdown of amino acids. You're going to see also uric acids, glucose. You get a little bit of glucose being filtered out. You also see some amino acids being filtered out. And salts, that's going to be your solutes, right? So sodium, bicarb, things like that. So all that gets filtered out at the level of the glomerulus. Once you get into the proximal convoluted tubules, then you get the reabsorption. You're going from the filtrate back into the blood. So like I said, follow the arrow. So you're going from the filtrate here, right back into the blood, back into the capillaries, right? So you have those peritubular capillaries. So you're going to get a lot of water coming back in. So it's like 99% of all the water that's being filtered out is going to be reabsorbed. You also get reabsorption of glucose and salts. Then when you get towards the distal convoluted tubules, you'll see excretion of things. So you'll actually see the excretion of things like drugs. You could see the excretion of things like creatinine, as well as hydrogen ions. And so when you see the the secretion of hydrogen ions, drugs, and creatinine, the hydrogen ions are going to contribute to the pH levels of the urine, right? So urine generally tends to run a little bit on the acidic side. So it's going to be lower in pH. That's going to be due to hydrogen ion secretion. You're also going to excrete a lot of drugs at the level of the distal convoluted tubules. So oftentimes drugs are going to be metabolized by the liver. And then drugs can also be metabolized and excreted through the urine. And so that's what we're talking about when we say that drugs can be metabolized through the kidneys. And then we already went through all of these different regions over here, but let's, we just talked about the proximal convoluted tubules. Let's now get into the loop of Henle. So the loop of Henle, that's going to be the region of the kidney that eventually dips down into the renal medulla. Because recall that all these structures over here on top, glomerulus, proximal convoluted tubule, distal convoluted tubules, those are all in the renal cortex, right? It's going to be on like the more outer layer of the kidney. When you get into the renal medulla, that's where you find the loop of Henle. That's also where you find the collecting ducts. So let's talk about what's going on at the loop of Henle. There's two major sections in the loop of Henle. There's going to be the descending loop of Henle, and there's going to be the ascending loop of Henle. So at the descending loop of Henle, you're going to have a thick section over here, but you're also going to have a thinner section as you go further down towards the medulla. You're also going to have a thin region in the ascending loop of Henle, and then you're going to have a thicker region in the ascending loop of Henle as well. So let's talk about what's going on at each of these levels. One thing to keep in mind about this chart over here, it shows what's going on with water reabsorption. Now, take a note that water is mostly going to be reabsorbed at the descending loop. Okay, so remember, the majority of water is being reabsorbed at the level of the proximal convoluted tubule. As more filtrate makes its way down into the loops of Henle, more water is also going to be reabsorbed at the descending loop over here. And so, as you get water being removed from the filtrate, what's happening to the to the urine concentration? Is it becoming more concentrated, or is it becoming less concentrated? Less concentrated? So if you're removing the water, right, and you're leaving behind all the solutes, what's going on with the overall concentration of the urine? Do you think it's going to be like really concentrated, or is it going to be less concentrated? So it's going to be a lot more concentrated. So in the loop of Henle, you're seeing further concentration of the solutes. Okay, so solutes are going to be getting left behind. You're going to increase the overall osmolarity of the urine and the filtrate, and you're removing the water, so it's becoming more and more concentrated. So that's going to be water reabsorption taking place at the descending loop of Henle, and we're going to talk about that in more detail a little bit later on. And then once you start getting into the ascending loop of Henle, notice no water is going to be reabsorbed at that level. So the ascending loop is going to be actually impermeable to water. The descending loop, permeable to water, ascending, impermeable. Once you get to the thick section of the ascending loop, that's when you start seeing sodium, chloride. You're going to start seeing like salts and solutes being reabsorbed into the blood. Okay, so it's going from the filtrate back into the blood. So that would be happening at the ascending loops. So we'll go into more details about those in a moment here. So here's another image of that. This is actually a better image because it actually shows you where the water is coming out. So as you notice, the osmolarity, so that's going to be the overall concentration of the urine. The overall osmolarity of the urine is pretty low when it first gets into the first portion of the loop of Henle. Okay, so 300 milliosmoles, so it's pretty dilute. Okay, as you start moving your way down the descending loop of Henle, that's where you have water being reabsorbed. It's going into the blood. Okay, so it's getting removed from the filtrate. It's getting removed from the urine. Watch the overall concentration of the urine. It's getting more and more concentrate. And so we measure that in milliosmoles per liter. Then, as you start getting into the ascending limb, that's where you're not seeing any movement of water. The ascending limb over here, it's going to be impermeable to water. You're not going to see any water movement taking place over here at the ascending loops. But you are going to see sodium chloride being pumped at this level. So sodium chloride is actually going to be removed from the urine. So then note the milliosmolarities. The milliosmolarities once again start becoming more diluted, right? So now a lot of that sodium has been removed. Now the urine again is going to be dilute. So it starts dilute at 300 milliosmoles. It gets very concentrated as you get down to the bottom of the loop of Henle. As you go back up to the ascending loop, then you start seeing solutes being removed. And then now all of a sudden, again, the urine or the filtrate becomes more dilute. So you have a lower milliosmolarity. Does that make sense to you guys? I want to make sure that we know like which what direction water as well as solutes are being directed into. So just know that the thin segment, you're not going to see any movement of solutes. Once you get down to the descending loop over here, that's where you see the movement of water. And then once you get to the ascending loop, you see impermeability to water, and you're going to see movement of sodium chloride at that level. Cool. So that was the loop of Henle. Let's talk a little bit about the distal convoluted tubules. So the distal convoluted tubules, if you look at the lumen, there's going to be very few microvilli, right? Because the distal convoluted tubule, majority of its function is going to be to help secrete, right? So filtration at the glomerulus, reabsorption at the proximal convoluted tubule, as well as a portion of the loop of Henle, and then ultimately secretion from the distal convoluted tubules. So in terms of the cell types, like I mentioned, you're not going to really see any microvilli. There are going to be a few, but it's going to be very sparse, much less than you would see in the proximal convoluted tubule. In the distal convoluted tubule, you're going to see movement of sodium chloride, bicarbonate, water as well. And then this is all right before you get down into the collecting ducts. So, Now, in terms of what the distal convoluted tubule can do, so there's going to be a lot of functions with the distal convoluted tubule. As I mentioned earlier, with hydrogen ions, you're going to see hydrogen ions being secreted into the urine. Okay, so that's what allows for the urine to become a little bit more acidic, right? So it's got a lower pH. So you're going to see hydrogen ions and acids moving into the urine. You're also going to get drugs being released into the urine, right? So if you're taking medications, for instance, even like recreational drugs can be excreted at the level of the kidneys. And then also toxins that start accumulating in the body, those are also going to be secreted at the level of the distal convoluted tubule. Aldosterone. So remember we talked about aldosterone and its function in reabsorbing sodium. Aldosterone is going to be acting on the distal convoluted tubules. And so as you have aldosterone bringing sodium back in, water is also going to be brought back in to the blood at the level of the distal convoluted tubules. Otherwise, the distal convoluted tubules, you're mostly going to see secretion. But in the presence of aldosterone, you're going to see a little bit of reabsorption as well. Other things that you're going to see as well is calcitriol, as well as parathyroid hormone. If you guys remember when we talked about parathyroid hormone, it's going to allow for increased levels of calcium in your body. What's the hormone that opposes that? Do you guys remember? It's secreted by the thyroid gland. Huh? So the parathyroid hormone increases calcium. What helps to reduce calcium levels? Do you guys remember? Calcitonin. Good, excellent. So that's released by the thyroid gland. So if your calcium levels are low, then parathyroid hormone is going to kick in to help increase your overall calcium levels. And then calcitriol, there's going to be an effect here on vitamin D3 as well. So that's when we hear about vitamin D3 being converted to its active form, that's going to be happening at the level of the kidneys as well. And vitamin D3 is going to be playing a very important role in allowing for the absorption of calcium. And then in terms of a water reabsorption that's also taking place at the distal convoluted tubule, antidiuretic hormone is going to have the bulk of its effect on the distal convoluted tubule. And of course, antidiuretic hormone, you're preventing diuresis, so you're preventing the secretion of water. You're trying to encourage the increased absorption of water. And so we're going to talk about aquaports in a second and how antidiuretic hormone plays into that. So sodium chloride reabsorption taking place at the level of distal convoluted tubules. Sodium chloride comes in. This is with especially with aldosterone release. If you have too much aldosterone release, you're also going to be excreting a lot of potassium, and so you could become eventually hypokalemic if you secrete way too much potassium. And so that's all going to be responding to aldosterone secretion. Okay, cool. Now let's finish up here talking about the collecting ducts. So if you recall, collecting ducts are going to be really important in doing those fine-tuned adjustments to the urine before it gets excreted, right? And so you're going to be adjusting the levels of water as well as the levels of sodium chloride. Now the collecting ducts are also going to be responding to aldosterone as well as antidiuretic hormone. So now if you recall, the two major parts that respond to those two hormones are going to be distal convoluted tubule and the collecting ducts. Okay, so at the distal convoluted tubule and the collecting ducts, if you see aldosterone being released, then you're going to have sodium being brought back in to the blood at the level of the collecting ducts. Antidiuretic hormone, you're going to prevent the release of water at the collecting ducts as well. Okay, moving on. This is a good overview of what's happening at each of these levels over here. So at the level of the proximal convoluted tubules, that's where you see the movement, the reabsorption of water, sodium chloride, the reabsorption of glucose, as well as amino acids. Once you get down into the descending loop of Henle, that's where you're going to see the movement of water, right? You're concentrating the urine. You're going to be pulling water back into the blood. The ascending loop of Henle, impermeable to water, so water stays in there, but you're going to see the movement of, for instance, sodium chloride. You're going to start getting more, you're going to remove those solutes, so now you're diluting the urine again. Then once you get to the distal convoluted tubules, you're going to see antidiuretic hormone and aldosterone coming into play. That's going to help affect sodium reabsorption, water reabsorption, or preventing the release of water through antidiuretic hormone. And that's going to also happen at the level of the collecting ducts as well. So the distal convoluted tubule and the collecting ducts are going to be playing very, very similar roles, right? Especially in response to ADH and aldosterone. Now let's finish up here with the effects of water, okay? So if you are very, very hydrated, you drank a lot of water, then you're going to have a little bit of the antidiuretic hormone released, right? And so if you have lots of fluid volume, you're not going to want to retain more water. So you're going to try to inhibit the release of antidiuretic hormone so you can hopefully produce a lot more urine, right? So it's going to increase the overall volume of urine. Okay, so here's a question that kind of plays back into when you first talked about antidiuretic hormone. Where does antidiuretic hormone get produced? Or gets released, rather? You guys remember? Posterior pituitary. Good, good, excellent. Now, with diabetes insipidus is kind of interesting. With diabetes insipidus, the patient does not release any antidiuretic hormone. So a patient with diabetes insipidus, they're going to be diuresing. They're going to be producing a lot of urine. So a patient with diabetes insipidus, they might get a large urine volume, and as a consequence, they're also going to get polydipsia. Have you guys ever heard that term before? Polydipsia just means increased thirst. And so they're going to be drinking water all the time, and they're going to be producing a high volume of urine every day. So a very unpleasant condition. Now, if you're dehydrated, you're going to want to try to reduce the amount of urine production, right? So you're going to want to reduce the urine volume. So you're going to get a lot of antidiuretic hormone as a consequence. Now, if you notice in this chart here, antidiuretic hormone, it's basically going to block the ability for water to be removed. So it's going to basically allow for water to get reabsorbed at the level of the distal convoluted tubule and collecting ducts. And the way it does that is through the creation of these aquaporins. Okay, so whenever aquaporins are produced, right, they're going to be entering into the plasma membrane of these different regions, right? So the distal convoluted tubule and collecting ducts. The aquaporins are going to allow for water to re-enter into the blood. Okay. So that's all I have for part 1 of chapter 24. And I only made a couple questions here, so we're going to be getting out a little early today. Hope you guys don't mind. Anyone having a hard time logging in or what? Well, I got your guys' participation from the last quizzes, so I'll go ahead and start it. All right, so first of all, glomerulonephritis. We're going to talk about that towards the end of chapter 24. There's a lot of things that can cause glomerulonephritis. One example would be a post-streptococcal infection where you have like antibodies that start attacking the actual glomerulus itself. When you have glomerulonephritis, what's going to happen is that it's going to damage the glomerulus, so you're not going to get a proper amount of like GFR, right? So you're going to get less filtration at the level of the glomerulus. That's going to cause increase in blood pressure, right? Because you're going to have an increased amount of fluid retention. And so we're going to talk about glomerulonephritis later. So one thing that you could do to treat increased blood pressure from glomerulonephritis would be ACE inhibitors. Lisinopril is a good example, captopril. A lot of the pril drugs are going to be ACE inhibitors. ACE inhibitors are going to prevent the conversion of angiotensin 1 into angiotensin 2, right? So angiotensin 2 is the active form. You're not going to get any vasoconstriction as a consequence. And then as a consequence of that, you're not going to get the vasoconstrictor, angiotensin 2. You're also going to get a reduction in the overall blood pressure. That's why those ACE inhibitor drugs are very, very useful in treating hypertension. All right. So angiotensin 2, just keep in mind, it doesn't just affect vasoconstriction. It's also going to be involved in aldosterone secretion, right? Angiotensin 2 is going to help stimulate the adrenal cortex, the zona glomerulosa, to actually start releasing aldosterone. Thirst is also going to be an important thing that's stimulated with angiotensin 2. Okay, so angiotensin 2 does all of these things. Okay, it's not just vasoconstriction. It's going to really try to do everything it can to help increase blood volume and fluid volume. Awesome, good job. Yeah, so when you're exercising, of course, you want to be able to bring as much blood as possible to the regions that have high metabolic demand. Part of that is reduction in blood flow to the kidneys, which could eventually, potentially, result in renal injury if done for a prolonged period of time. All right, last one before we dismiss. All right, just make sure that you know the ascending portion that goes back up, impermeable to water, okay? That's one very important factor. So you're going to see movement of water at the descending loop, okay, when it goes down, right, down towards the renal medulla. All right, good job, guys. I'll see you all on Tuesday. Have a good one. What's up? Yeah.